So good evening, everyone, and welcome to Series 138 of the Africa Healthcare Network Fireside Chat Series. My name is Dr. Amar Swalian. I am a consultant nephrologist working with Sri Hindu Mandal Hospital in Dar es Salaam, Tanzania, and it is my pleasure again to welcome you to the fifth of 8 sets of research webinars presented by the International Pediatric Nephrology Association in preparation of the IPNA 2025 Congress in Cape Town, South Africa. And we're grateful to IPNA for teaming up with AHN for this Fireside platform. IPNA and ISN have assisted in funding for training in pediatric nephrology throughout Africa and the rest of the world. And the aim of these webinars is to encourage junior career researchers in Africa and beyond to develop research questions and ideas, perform robust research, prepare abstracts for the IPNA 2025 Congress, closing date for which is, by the way, 2024 May, and also develop mentor and mentee relationships. So hope everybody's excited about that. I would like to introduce both our moderators for tonight. The first one being Dr. Devashni Reddy. She is a consultant pediatric nephrologist at the Tygerberg and Red Cross Children's Hospital in Cape Town. She's also an honorary senior lecturer at the University of Cape Town. Joining her tonight will be Dr. Privilege Makanda Charambira, who is a specialist pediatrician and pediatric nephrologist currently working with the Welwitschia Hospital in Walvis Bay, Namibia. Her passion is to see all children with kidney disease across Africa and aspires to come up with solutions in managing children in low-income settings. She's involved in basic pediatric nephrology training programs in Namibia. I would like to welcome you both to take the presentation over.
Good evening, everyone, and welcome to the fifth in this research series leading up to IPNA 2025, which we're very excited about. It's a pleasure to moderate this evening with Dr. Privilege Makanda Charambira, who I know is Privy. And it's an exciting topic, an intimidating topic, and I'm hoping to get a lot of things with regard to statistics and data analysis simplified for my own benefit as well as everyone else's. So I'd like to invite you all to put any questions you have during the talk into the chat box, and we'll address those at the end of the talk with Professor Parekh. Or you can raise your hand at the end of the talk and we'll unmute you so you could ask your question directly. Okay, Privy, over to you.
Thank you so much, Devashni. I'm really honored to present our distinguished speaker for today, Professor Rulan Parekh. She is the Vice President Academics at Women's College Hospital. Professor is also a staff nephrologist at Women's College Hospital, as well as Hospital for Sick Children. She is the FM Hill Chair in Health System Solution. And to just put the cherry on top, she is a professor in medicine, pediatrics, epidemiology, health policy and management evaluation at University of Toronto. We are really excited and ready to learn a lot from you, Prof, tonight. Over to you, Prof.
Thank you so much. And thank you so much for Yuri for helping me with the slides. I'm really looking forward to everybody coming in 2025. So my talk today is really to focus on data collection, validity, and descriptive statistics. I'm going to try to go through this mostly using examples. And then my hope is that we'll have lots of time for questions as you're thinking about your own projects. You go to the next slide, please. So we're just going to do a recap of what I talked about last time. I'm going to talk about data collection, validity, and then go over some descriptive statistics using some examples so that hopefully it'll help put some of the work that you do in context. So in general, what we're always trying to do with clinical research is determine is there cause and effect. Does an exposure to some risk factor actually lead to disease? Exposures could be blood pressure. Does that lead to kidney disease? Does APOL1 high-risk genetic status lead to chronic kidney disease? It's important to recognize that within clinical research studies that we can only test association, but not causation. But however, if we have a clear study question, a study design, and good data collection, we can potentially infer causality. So I will go back to this premise repeatedly because it's really important that as you're thinking about what's the risk factor you want to look at, what's causing disease, what's unique to your areas and your different countries and your local epidemiology, it's important that you develop this conceptual model. And as you develop the conceptual model, what you're going to do is really try to think about the cause and effect. What's a confounder? What's an effect modifier? But really, what are the factors that you need to think about? And what's the specific outcome that you want to take a look at? So I'll always go back to this point about asking the right study question. If you have a clear and focused study question, you can determine the right study design, the right study population, and the appropriate analytical methods. A lot of people just start something without asking the question specifically, and then you can't then go on and choose the right study design. So it's really important, because if you get erroneous study design or analysis, if you have a protocol that isn't fully developed, if you don't have clear definitions, then what happens is your results are not really relevant and the interpretation will be difficult. So you want to have clear objectives. And this is how I talked about last time. You frame your questions. So go back to the PICO. So patient population of interest, what your intervention or at least your exposure is, who you're comparing them to, what's your outcome of interest, and what's the time frame, and what's the settings that you're going to do. And these things are really important to understand. And if you could do this every time you're planning a study, then you'll be able to make sure you frame everything you need to think about in that question. And it's important to remember that, because we can't test everyone in the world, what we're trying to do is take a study sample population, infer to this larger target population, and make inferences using statistics. What we want to try and intend is that will then infer some biological effect. And then we can see if that really proves our hypothesis. And so it's important that you always think about your study population. And what we're going to talk about a lot today is how do you describe that study population so that you understand if you are biased or not. So, and also to remember that the utility and the validity of study design goes from the lowest level at case report, case series, which not that they're bad, but actually can actually be a great starting point for depending on what your question is. And then you can move all the way up to clinical trials, which has the strongest study design to infer causality. So again, we're trying to look cause and effect. And so this is called causal inference or causality. And what you can see sort of if you take the study designs on your left, what you need on your right, or what you actually are able to do in terms of this cause and effect is, if you get to a clinical trial, there's a temporal relationship. So you were exposed first to the risk factor, and then over time develop the outcome. You can then get strength of association or dose response by doing case control or cohort studies. You get consistency of association, and you can do biological plausibility in the clinical trial. But what's important to recognize is a lot of those things you can't do in a case report or a case series or even a cross-sectional study. Therefore, you're studying something, but you can't infer causality because it isn't a rigorous study design. So it's really important, if you can, to try and do a case control cohort or clinical trial, because those study designs are going to get you closer to truly causal inference. So again, with your study design, you want to minimize bias. You want your study population to be reflective of your target population. You want to collect information in a standardized fashion, which we're going to go over a bunch today, both exposure and outcome. And this is really important. Otherwise, you get potential recall bias or measurement errors. And you want to make sure that you can adjust for confounding factors that are associated with both the exposure and the outcome. And you want it to be generalizable to a larger population. So I give this black box warning a lot, and I'll probably say that it's a lot. No statistical test can aid a study that was poorly designed, that has significant biases, and lacks data validity. And people will say, but there's a significant p-value. It doesn't really matter, because if your study design is flawed, your recruitment was flawed, and the way that you collected data, you can't fix any of those regardless of what your p-value shows you. In fact, the p-value would be completely erroneous and completely wrong. And I think the last thing is, just because you find an association doesn't mean it's causation. And so again, causal inference is something that's very important for us to try to prove, but what we need to do is really make sure that we have data we have well thought out studies to be able to do that. I'm going to go back to your study population. So you want to collect data on the study population to demonstrate the likeness to the target population. This is often the table 1 and figure 1 in your paper. And you divide the study population by the exposure, those exposed versus those not exposed. And examples could be, I'm going to look at my pediatric nephrology patients with FSGS, and I'm going to describe who is the APOL1 high risk carriers and who are the APOL1 low risk carriers. I'm going to describe those on TAC versus those not on TAC. So those are examples of risk factors, and you're taking your table 1 and your study population, and you're describing who are exposed and who are not exposed. Sometimes people go table 1, and what they do is they describe the outcome, who got kidney disease versus who didn't get kidney disease. But in fact, your table 1 should always be by exposure. What's the risk factor that's leading to an outcome or type of disease? And so it's very important that you think about that, because often people confuse that in publications, and those analyses are actually erroneous. So this is a paper I showed before. This is progression of chronic kidney disease among Black patients attending a tertiary hospital in Johannesburg. This is a study by Sarah Necker. The reason I'm showing this study is just to really take a look at the table 1. So instead of putting in a table, actually they did it by figure. And so here they are describing their population, and they're giving you the raw data, which is really important because you want to know what's the distribution of their exposure at baseline. So how many were in stage 1, stage 2, stage 3, stage 4, stage 5 kidney disease. And as you can see, the majority of them had evidence of stage 3 kidney disease. What they also did is that they included another figure, taking a look at how many people had the outcome. And what they wanted to do was talk about the composite outcome versus a single outcome. And so what's important was, again, they provide the raw data, which is really important to see. We don't even get into fancy statistics, and we learn lots of things already about the study population. So the majority of patients they had stage 3, and when they were taking a look at different outcomes, in fact, you could see that sustained decline was actually the most common feature that people had. So again, what they were doing in that study was they were saying, what CKD stage are you starting with, and how fast is your progression to kidney disease? So again, if we're going to take a look at the exposure and the outcome, what we want to understand for the exposure is, what is the specific exposure of interest? How are you measuring it? Is there a measurement error? And is there a composite of things that you want to measure? For example, let's say you actually want to take a look at the exposure of people to heavy metals and getting kidney disease. So there's a way to actually look at each individual marker of iron, cadmium, aluminum, for example, but there's a way also to measure it all together in one way, a multi-metal exposure number. And so it's always important to think, is there a valid way to measure something? What's the way it's measured already in the literature? And what's the most reproducible way that you can measure something? And so I'll always go back to this really simple questions when I'm asking any of you as you're designing your projects. What's your exposure, and how are you measuring it, and how are you defining it? And you need to think through all of this even before you'd start collecting any data. Then the next thing is, what's your outcome? What's the primary outcome? Do you have secondary outcomes? Do you have a composite of outcomes? Again, this is very important that this is all thought through. How is that outcome measured or ascertained? And how likely is that there might be some measurement error? And what's the potential for misclassification? And so these are really important things, again, that you need to think about. And so for both exposure and outcome, I'll always ask those questions, but I'll also ask you about validity and reproducibility. You have to be clear for each data collection point that you're collecting. What is the definition? You need to make sure that you think about, is it patient self-report? Is it medical record? Is it a survey? Is it urine or blood measurement? And all of those have their own issues with recall bias, potentially, or measurement bias that could occur. So you need to think about how you're measuring something, because everything is at risk of bias. And the other thing I'll say is, whenever nephrologists are asked for a study, they collect way too many data points. So you're better off collecting fewer things and making sure it's complete and trying to collect way too much. So this is what I mean by validity and reproducibility. So everybody wants, and this isn't a proper bullseye, but imagine it's a bullseye and you want to get straight in the middle every time you ask a question. So we'll ask a question about, have you had high blood pressure? Yes or no? And you just ask a simple question. You hope that you always get the same answer. And if you ask somebody again, if there's someone with the same answer, then the idea is that if it's reproducible, it'll always be in the same way, just like B. So it's systematically in the same place. If it's like A, then it's random. And so you have to understand that if you are asking a question a certain way and you've got randomness in that question asking versus it's all systematic, you just need to know whether it's random or you think it's systematic. And one example is, I actually asked a question about how many people were living in the household, and we had 2 boxes. And because of the country that it was being done in, they used those 2 boxes differently. The 2 boxes were available for the total number, but it was decided by some people to put how many females in one box and how many males in another box that were living in the family household. And so that was relatively random in that it happened differently in different countries when they were doing that questionnaire, but it was systematic by the country that was doing it. And it was partly cultural in how they did those questions. So piloting your questionnaires or piloting how you collect the data is really, really important. So again, ascertainment and definition of outcomes. So when you're describing things, it's really important to take a look at it and recognize that you might actually think that hard outcomes are less subject to misclassification. Example is a measurement of serum creatinine versus defining end-stage renal disease, angina versus transmural myocardial infarction, transient ischemia attack versus completed stroke, and urinary tract symptoms versus culture-positive UTI. These are all examples of how you can actually define things differently. But what's really important to recognize is that symptoms itself are quite soft, and it's very important that you think about what your actual outcome is. And the hardest outcome, for example, is death. And that's something that's easier for people to classify. So the types of data are qualitative or quantitative data. You can have discrete or categorical. What's important that the values assume only whole numbers or qualitative. And so you can have nominal, male versus female, so this dichotomous. You can have ordinal, so low, medium, high. You can have intervals, or you can have ratios, or you can have a continuous value. And this is really important to recognize that, in fact, you also have to think not only about the study design, your questions, but now what kind of data do you actually want to collect? So I really like taking a look at the distribution of all the data. I often have students who quickly rush to go to all the fancy statistics. But you can't do the fancy statistics unless you actually know the frequency or density of each value for every variable you have in your study. And what you want to do is take a look at the distribution so you can understand your study quite well. And there's lots of information that we understand when people show us the distribution of the data. And I would encourage all of you, for whatever your analysis is going to do, I think that the majority of you will be able to show some descriptive statistics for your abstracts. And that in itself will be really important. And you don't need to get into fancy statistics. So why is it important to understand distribution? Well, it's important to understand because there's a spread over of your data over the distribution. And what you want to understand is what's the mean, which is the average plus the standard deviation. What's the median, which is the 50th percentile and the interquartile range. And what's the mode for the most frequent value. And it's important to recognize that it's sensitive to outliers, and you can sometimes have a bimodal distribution, of which is incredibly important to also report within your population. Your distributions could be skewed either left to the right. So you can have a skewed distribution to the left, and you can have a skewed distribution to the right. And here's evidence of a bimodal distribution. And so actually understanding each of these for your variables is incredibly important. What I do also is I really like these box plots, which is another way to describe the distribution of variables that you've categorized that don't have a continuous number. And what you've done here is you've now categorized them and able to show this box plot. The middle of the box plot, which you can see that line, is the 50th percentile. So that's the median. The interquartile range goes from the bottom of the box at the 25th percentile to the top of the box at the 75th percentile. And those little lines that we call whiskers with little bars on it, those are actually from the 75th or the 25th percentile out to the lowest. So you're talking about the entire range. But what it shows you, if you look at the first figure, is you can actually see that there's, in fact, the median, which is the middle, is not too different from all three groups. But you can see the last group is really skewed because look at the whiskers. Those little lines are quite large. That means it overlaps between the first box plot and the second and the third box plot. But you see those little dots at the bottom, it actually shows you that you've got some outliers. And that's an important thing to know. So with outliers, the question is, how good is the data? And why are there outliers? Are they real? Or is it not real? If you look at the right, it's the same kind of thing. There you see the distribution with the median is actually quite different in the groups, but you can tell in the middle group, in fact, it's a very tight range. So there's no whiskers. Everybody falls between the 25th and the 75th percentile, and there's no outliers. And that's an important thing to know. And so these are just examples of information that you get from a box plot, which are really helpful and a great way to present data. So why do we use these different summary measures? So if you have a mean, it's intuitive because all of us understand mean. We understand average, but it's sensitive to outliers. So in general, I prefer to present the median. It's not so sensitive to outliers, but it's less efficient when you're doing analyses. The mode only gets used at certain times. Range is really important to show, but if you're going to give median plus or minus standard deviation and range and not show a figure, then in general, you can actually give lots of information with that. When you present the median, you often give the interquartile range, and you can actually then compare them statistically among each other, which is great. Standard error should not be done at all in any clinical research studies because it doesn't account for the sample size of the population, and that's really important. So in some lab studies, people show standard error, But in fact, that's wrong, because if you have a very small study population, your standard error is extremely small. And so it's actually falsely small if your population is very small, and it should actually be much, much higher. And so in general, I would say standard error shouldn't be used in any of your clinical research studies. Now I'm going to go through a series of examples here with blood pressure. And so when you take a look at blood pressure, in general, we get this normal distribution in the human population, especially when you take a look at children. And we know that in children at every age, that there's a different distribution that occurs by age and by height. Hence, we have these blood pressure percentiles. What's important to realize is when you take a look just at the top of the bell-shaped curve, you can see that it breaks down to the median is right at the middle at the top. And then you can go out to the 5th percentile, which are the small tails on both sides. And so that's really a normal distribution and a normal bell-shaped curve. But if you look below, what I think is important is that they also describe cumulative percentages. So what's great is when we take a look at children and looking at percentiles, we're able to say that when you're in the middle, you're the 50th percentile. And as you go above into the 84th percentile, into the 97th percentile, and the 99th percentile, we can actually look at those distributions and give you the cut points that were generated for the different task force and blood pressure. Those percentiles are really helpful when we're trying to understand how we're actually going to take a look at different patients. Then if you go down to the Z-scores below, we then convert those percentiles. Again, we take a Z-score that says, okay, if I'm going to look at the general population, am I 1 standard deviation or 1 Z-score above? Am I 1 below? And this allows us to compare children across the age groups with different heights and different sexes so that we can actually do comparisons of apples to apples because we can't use their raw data. So this is an example of how we take blood pressure and are able to actually look at it in many different ways and be able to compare the distribution from group to group. So I'm now going to go through a series of questions, and perhaps I'm going to just ask somebody if you can monitor the chat. I'm going to go to the next slide, please, Yuri. And don't press the next slide until I ask you to. Thank you. So this is an example of what a data set could look like. You have an ID number. You're saying, do they have high blood pressure or not? Yes or no. 0, 1. What their actual systolic blood pressure is, whether their blood pressure is under control. You're going to define it by their interval range. You're going to give their systolic blood pressure Z-score. And we're going to give them their score again. Is it less than 1 or greater than 1? What's important about this data set is we've given an ID number that's numbered. We never do letters. You should never do patient's initials. It should be completely de-identified. You want everything in your Excel sheet, or REDCap preferably, to only be numbers. You want everything to be a number because it's much easier to do analysis that way. And you want your Excel file to only have numbers. So if you decide to use Excel, you take your master list. It's very important that you lock down certain variables that can't be deleted because errors do happen. And what's important is as you define certain things, you need to make sure you're very clear about those definitions, such as hypertension, 0 and 1. And what's important is that you're able to go back and actually make sure that everything fits into this idea of it's a discrete number, or it's been a number that's coded for a categorical variable into either 0, 1, or 2, or maybe higher if you need it. Like blood pressure control, like range, and then systolic blood pressure Z-score is actually a raw number, as the systolic blood pressure number is a raw number. So I just need you guys to understand this general premise of what the data set looks like, and that we're now going to use for a series of questions that we're going to ask. And I just want to make sure that you guys understand what that Excel sheet looks like and how we're going to define some of it. So the question is hypertension associated with kidney disease progression? I want you to choose the appropriate variable type. Should I use a ratio, a continuous number, a nominal number, an ordinal number, or an interval? So before Yuri hit the answer, can people put in the chat what they think hypertension is and the type of variable it is? You can choose between A and E. Okay, I'll give just a few more seconds. Okay, I'm going to stop now. If you go, Yuri, to the answer, you hit the next. Yuri, are you able to hit next? It's nominal. So I'm going to make everyone go back to the question. Is hypertension associated with kidney disease progression? So I've already made a decision that the question is hypertension. I haven't said blood pressure. I haven't asked, I've already effectively said hypertension versus not hypertension. So then that would mean that I've already categorized it. So I've made it into a nominal variable. It's not a ratio, it's not continuous, it's not ordinal, nor is it an interval. So why is it a nominal or discrete? It's discrete because it's hypertension, yes, no. It may be based on 3 different ways that I got data. I got data on were they on medication, yes, no. Were they at an elevated blood pressure percentile, yes or no. And do they have a self-reported history of hypertension? And then I basically take all 3 of those and then categorize and collapse everybody into yes versus no. And then I can do a survival curve, for example, yes versus no. Does that make sense to people? This is really important to understand, because if you go back 1 slide, Yuri, it's really important that you understand that my question is really what sets me up for everything. So it goes back to what's my study question? Then how am I going to define that study question? And then how will the data actually be collected? And so those are the things you need to think about. If you go to the next slide, the next question is controlled blood pressure associated with kidney disease progression? Now I'm asking about controlled blood pressure. Now, choose the appropriate variable type. You can choose again, and we'll wait a second. So don't be shy in answering. Okay, so most people think it's a continuous one. You go to the answer. So it's ordinal, because again, I'm defining controlled blood pressure. So remember, among children, we can't do controlled blood pressure like adults do and say, well, and everybody's less than 120/80. If it was, you could take a continuous number and I would agree with you. But in children, the issue is that we actually need to look at a specific number that be able to say, we need to be able to take a look at the Z-score so that we're actually able to compare across the age groups, across the sexes, and across the height. So here I've got a discrete and ordinal number. So what I'm doing again is my blood pressure well controlled, poorly controlled, or uncontrolled? And what I've had to do is I've had to take their medication number, whether they're on medications or not, and I've also taken their blood pressure. So let's say you are well controlled. It means you would be on medications and your blood pressure percentile would be less than the 97th percentile. If you're poorly controlled, you might still be on medications, but your blood pressure would be greater than the 97th percentile. And if you're totally uncontrolled, sorry, I did it reverse. If you're totally uncontrolled, your blood pressure is basically you're on medications, but your blood pressure percentile is greater than 99th percentile. If you're well controlled, it's less than 97th, or perhaps you might define it as the 50th percentile and on medications. And so what's important again to recognize is I had to define what controlled means. I have to be able to then give the blood pressure categories and think about how I define it. I have to think about the variables I need to use to define it. I need to recognize that there's a ranking order among them. And the reason why that's important is because then I assume the risk is the same between groups, from being well controlled, poorly controlled, and uncontrolled. And so that's just something that you need to think about. And so that's why this is another example. You could have done it also by looking at Z-score alone, as continuous potentially, but you couldn't account then for those who are on medications or not on medications. And so that would have been a little bit harder to do. So again, study question is important. How are you defining the actual exposure is important. And then thinking about what data collection points need to go into studying that one parameter of controlled blood pressure. So now I get into the question, is systolic blood pressure associated with kidney disease progression? I'm gonna let you all answer this one. And this one has 2 right answers. Okay, so most people say continuous. If you go to the next, the answer should be, it should be continuous, or it could be interval. And I'll show you what interval means right now. So if you go to the next slide, what an interval means is, and this happens often in adult studies, and I'm just showing you this mostly for adult studies, but could also be in pediatrics in a different way. But if you look at systolic blood pressure, often you'll see in adult studies that they give these intervals, and you can use those intervals as your exposure, and you can see what the count is in the distribution in the boxes below. And the blood pressure is measured at a single or multiple visits, and you effectively give clinical cut points. We could potentially do this in pediatrics if we did percentiles. Again, how many are between the 50th and 75th percentile, 75th to 90th percentile, 90th to 95th, 95 to 99, greater than 99, for example. So if you use clinical cut points, we could do something like that. And then that would be an interval, discrete, but an interval. Or you can actually look at it by the Z-score. So that's actually the continuous measurement I would use in children. It's using the Z-score. So what I've done below, I just wanted to show you, was that on the left, again, is that figure of the distribution. And then you can see that I've underlined in red where the Z-score was. And then if you take a look at the box plots on your right, this is the distribution of blood pressure by Z-score among all children that had middle aortic syndrome. And I'm just trying to look, sorry, it's the systolic abdominal systolic blood pressures by Z-score. So you can see that 0 is actually the third bar from the bottom, and actually the majority of them had elevated blood pressure. You can see that those who got medical management versus those who got interventional management, we basically said that every single year, what was the distribution of blood pressure by each of those groups over time. And what's interesting for this is, again, this is just distributive, descriptive statistics, nothing fancy. It's the raw data itself. And you can see that, in fact, by those two parameters of whether I intervened on somebody or I gave them medical management, the distribution of blood pressure was pretty similar all throughout. There's definitely some outliers that have very bad blood pressure by systolic Z-score, but this just tells you overall how they're doing. And so there's a lot of information that we get from this slide that we didn't need to really do any sort of fancy statistics. You can just describe the blood pressure and show that there isn't much of a difference graphically, and you're able to just present that data. And this is actually then comparing the Z-score to systolic blood pressures. And so this is a great way to do a comparison within children. So now I'm asking a specific question. This again could be different things. Is systolic blood pressure associated with kidney disease progression among children ages 1 to 10 years of age? So what would be the most appropriate variable type? I think everyone's shy. Yeah, most people are saying a ratio or interval. If you go on to the next. So it could be a ratio and it could also be continuous. And I'll show you how it could be both. Go to the next one. So this is now, I'm using a ratio above and below. And so again, what we've done is if you go back to the question, so the reason why I just want to go back to the one slide or actually just framing the question is it's important to note that when you're actually asking the question, I actually limited it now to a specific age group. And because I limited to a specific age group, I now no longer need to do all the Z-scores, perhaps all the same. Maybe I could do the percentiles because now it's a very specific age group and I don't need to look at Z-scores to do comparisons across age and cross sex necessarily. And also I can also take a discrete number to look above and below, and then it's easier if I do a narrow population. I just lost the slides, so hopefully they'll come back in a second. This is an example of, again, I'm doing counts, so how many are above 1, how many are below 1. And this is just a really simple way of taking a look at it, and it is a ratio. Often you don't really do this in blood pressure, but I'm just kind of forcing the issue to take a look at it for this example. So I'm just showing now another way to look at if you look at the left, we also look at Z-scores, not only for blood pressure, but here's an example for left ventricular index. So in children, very different to adults. You can do categorical for LV mass, for example, and say, do you have hypertrophy? Yes, no. But the better way to do it is to do it quantitatively and actually come up with the distribution, standardize it against a population. That's how you get the Z-score. And then you're actually able to do these types of studies where you're then able to say, what's the Z-score difference? And it accounts for all that variability that can occur by age, by sex, by height. And it's an important thing that we have within pediatrics that makes our pediatric studies a little bit more unique. It is more complex to do, but it is a better way for us to do analysis. So I've just given you blood pressure as one example of the many ways that you can actually do an analysis on blood pressure, but it always depends on my study question. And so it's important as you're thinking about what you want to do for your abstracts and trying to get ready to sort of for IPNA 2025, I want you to think about what your exposure is that you're interested and what your outcomes are that you want to describe. And then you have to really decide how are you going to define it and recognize that you want to know what the distribution is. You want to understand how to compare it from group to group. And the more you think about all your data, it'll improve precision and it'll avoid measurement bias. And that's really important because then it really improves the quality of the studies that you do. And then it effectively will have a larger impact down the road. So I just want to make the last point about influential data points. Go to the next slide. So in a small study population that you might have, this is a study just done with 38 students. We did it with a PharmD student who was basically interested in seeing if there was an association with vitamin D and blood pressure. And so what was important to understand was that they were able to actually take a look at vitamin D levels, put it into the different categories, also assess oral vitamin D intake, actually take a look at it both as a continuous measure as well as describing it by their overall dietary intake, taking a look at whether they took supplementation or not, what dose of supplementation, and calculating the total dose that they took. But what's really interesting is if you go to the next slide, when we took a look at it, and here we said, well, let's take a look at vitamin D, blood pressure. Now, these are only 38 children, and this is your average systolic blood pressure on the left. So in general, you can see that if I measure 25-hydroxyvitamin D, it looks like as your vitamin D level goes up, your blood pressure goes down. But I just want you to show you that with the scatter plot, data is sort of all over the place. I'm inferring it, and the line kind of looks like it's generally going downwards, makes me happy. But you know, there's a lot of information there, and maybe it's just by chance alone because you only got 38. So the larger your sample size that you can have, the more confident you can be that that line is actually true or not. But then when we measured how much they took, there was one person who's actually taking a huge dose of vitamin D. And then you could see that the blood pressure was kind of elevated, but not that much more so than other people. And so the question is, how much in this cross-sectional analysis is that one data point having on our analysis? And so in general, you need to look at data like this so you can understand all your outliers. And you may need to take your outliers out to see if the findings still hold true before you keep the outliers in. The outliers could be real. And sometimes we found some people, for example, that really had a blood pressure that was that high, or had a serum creatinine that was much higher than everybody else, or have a potassium that didn't quite make sense. But it's important that you really confirm that that data point is actually true, and then you have to decide whether you keep it or not. So if we took that data point out, what's very interesting is probably would straighten up that line a little bit, and we'd probably find no association. And so it's very important that you recognize that a single influential point can actually totally sway your data when you have very small sample sizes. So I think it's really important to have a larger sample size as possible for what you're studying, because it'll make sure that you don't have those influential points. And this is just, again, a scatter plot. And there are a couple of things I just want to show you here. If you see on the y-axis, you can see that at 300, there seem to be a whole bunch of dots at 300. It actually means because the study actually peaks at 300, so nobody can have longer than that. This is a mini mental status test. And so that's an important thing to know, that that's your threshold of your maximum. And so maybe those are influential points that you shouldn't even include in the analysis or not, because they peaked out. The other thing you can see is that when you create a line, a regression line, and you see the 95% confidence interval in the gray, you can see that towards the ends, where there's little data, the fanning goes out. And so, in fact, just realize that perhaps your regression line is not so good at the ends, but really only good where the bulk of the data is. So you have to be careful about where you make inferences with the types of analysis that you do using descriptive statistics. So I'm just going to keep on pounding on this thing about research question, clearly defined variables, the best laid plans for your study design, and strategies to minimize bias in your data collection. What you really need to do is plan. Keep it simple. It's better than having too much missing data. Be clear with your definitions and data collection methods. Descriptive statistics are incredibly important, and I would just really use those as much as you can for the data and for your abstract. It can give a huge amount of information, and you don't need to be fancy, because really the fancy statistics get lots of us into trouble. If you can tell a simple story really clearly using tables, graphs, and summary statistics on the variable distribution, you can tell a whole load about what you need to do in order to get your message across. And learning how to summarize the data in a meaningful way is really an important communication tool. So I'm just going to give you these resources. That BMJ has great online resources called Statistics at Square One. If you go back one slide, if you go to the Stat SI or you go to the Stat Primer, these are totally available and great resources. They're all online. There's videos you can watch. There's analytical data sets you can play with. And I would really encourage all of you to use these as much as possible.
Thank you so much, Prof. Parekh, for that brilliant talk. A lot of complex concepts, but I think also a lot of very important take-home messages about keeping things simple and being clear about your study question. I don't see any questions in the chat at the moment, so while people are still mulling things over, I have a question for you. I was just wondering what you thought in terms of the importance of doing a pilot study before you actually start your proper data collection, and how useful that is. If you could comment on that.
Oh, yeah, it's a great question. I think it's really, really important. And I think it's important because you can pilot everything, your data collection tool, how you're approaching patients, what questions you want to ask, what data you're getting back, how well that's working. And so I actually think piloting things are a great way to test everything to make sure that you're actually getting what you want.
Brilliant. Thank you. And then another question I had is, I think a lot of us as junior researchers, do you think a good starting point would be to start a database? And what would your advice be about that?
So I think a database makes sense, again, if you've got a clear study question or questions and a couple questions, and then figure out how you want to prospectively collect that you're able to go through and collect that data prospectively. Once you start collecting lots of data retrospectively, unfortunately, it gets messy. You have to go through medical charts that are incomplete. There's a lot of bias that occurs with that, and it takes a long time to fix and repair sort of all the errors that may occur. So if you can plan what you want for your study question, think about the data collection, pilot it, and then create sort of a data set or a database that you think will collect the information, then that would be helpful. You have to make sure that you're also collecting data on a regular basis and going through it to make sure that you're checking errors. The thing that I always feel bad for is that you only want to open a chart once if you can. You never want to have to go through a chart or have to go back to information years later because you recognize that the variable didn't make sense. So I would encourage all of you, if you've got access to REDCap, to use REDCap as much as you can rather than Excel, because you can actually create it in a way that you can put in those validity checks. So you can say max BMI is, I don't know, well, max weight is like 250 kilos. And so if somebody put 254, it would be impossible to fill that in. Even though that's a data error that might be happening because they actually want to say 25.4, but they put in 254. And so that's another great way that you can get people to ensure that you've got good data quality is, again, building it in REDCap with those data checks.
Thank you so much for that. My last question, I don't see anything in the chat, so I'm just chatting the whole time, unfortunately, but at least I'm getting my own answers for what I'm curious about. Is a lot of us would enlist the help of a statistician when we do our studies. Do you think involving the statistician from fairly early on in the study before you've actually collected all of your data is a better approach?
Yeah, in general, what I tell people to do is to plan the study, make sure they've got their research question clear, go out to meet the statistician with potentially what data you're going to collect, and have them review that before you do anything, and make sure that you've got the right data for your right study question and the right study design. Because often what happens is that people start, they collect data, then they basically are coming back to have somebody try and fix it, when in fact they had the wrong study design and the wrong data collection.
Great, thank you so much. I'm not sure if there are any other comments or anyone wants to raise their hand.
If I can just ask one question, Deveshni. Prof, looking at that graph that you presented during the talk, the one for nominal distribution, are there any particular instances where the percentiles give you more information than a Z-score? Where do we use percentiles? Where do we use Z-scores? I hope it's not a silly question.
No, it's not a silly question. I think it would always go back to what your question is. If you want to know how many children have hypertension in your study, like let's say you want to describe and say, is hypertension associated with kidney disease in my population? I'll just say children with sickle cell disease. Then you may describe how many of them have percentile blood pressures between the 50th and 75th, the 75th and the 90th, the 90th to 95th, and then above, right? Using some clinical cut points that we would use, because anybody greater than 95th, if you use the fourth task force, you'd say anybody greater than 95th percentile would have elevated blood pressure. Or if you decided to use the new cut points, you could do that again, and you'd have to code all of that and say, 95th blood pressure, but 12 millimeters of mercury, this is the cutoff kind of thing. And so you could do that. It depends on what your question is and what your population is that you want to do. If let's say you're doing screening of school-aged children, and you're going to screen 1,000 children, and you're going to see the association with microalbuminuria. At that point, I might say, you know what? I just want to know who's above the 90th percentile and who's below the 90th percentile. And so I'm only going to take 2 cut points, And that's all I care about. And I'm going to define my 90th percentile very clearly by age, sex, and height this way. And I'm going to say anybody who's less than that is going to be defined as having no hypertension. And the other ones are at risk for hypertension. And so and I would do that because those at 90th percentile may have an elevated blood pressure once, but they may also be at risk. They may also be at risk down the road. And so what you need to do is you need to be able to assess that again, and perhaps go back and reevaluate those children who are greater than 90th percentile, and then now do a second blood pressure on them. So I guess what I'm trying to say is, I think it almost doesn't matter what you're thinking about doing. What you need to do is go back to what your study question is and try to figure out what's the most appropriate way for you to define elevated blood pressure, and then decide how you're going to move forward. Does that make sense?
Definitely. Thank you, Prof.
Yeah, and I harp a lot about study design and study question, because often people come to me having done data collection, and then we have to go back and fix a lot of it. And so I think that's why I'm really encouraging you guys to really think about what that is, and happy to have you send me, if you want, even just like a short little couple lines in an email, and we can sort of go over what you might want to do as your study question and see if it actually makes sense. Again, think about what your exposure is and what your outcome is.
I have a question. One is, I think this series of research talks has sparked off quite a bit of action within our organization. And I think right from the nurses and doctors, we have about 25 research questions that have come out, 25 research questions. So how can we go about it? Number one. Number two is data comes from across 40 centers in 3 countries. And quite a bit of it is, of course, retrospective. Most of it is retrospective and collected on a regular basis by 2 statisticians. Ethically, what would be the clearance that I would need to do for all these studies? Because retrospective, multiple centers, 3 countries.
Yeah, so from an ethics perspective, depending on the countries, but in general, if you have to follow GDPR or Canadian ethics requirements, you would always need to have ethics approval of those sites to do the data sharing. So in order to do data sharing, I would say that that's best practice, is to have a data sharing agreement. The best way to make sure that your data validity across the centers and across countries is uniform is by making sure that the data collection tool has all the definitions as much as possible, in order to make sure that people are defining things exactly the same way. And then one thing that we do sometimes is, if there is a data point that is particularly, let's say, you need to adjudicate it because in fact you need to come up with a consensus, then you make sure that there's a group of 3 that are evaluating it, 2 people are taking a look at it, and then you have a 3rd person who helps mediate any differences. And then everyone can reconcile that. For example, let's say you wanted to define, I'm trying to think of, often in the adult studies, we have to define, do people have evidence, like was that a heart attack or not a heart attack? And so, or let's say you have a UTI or not a UTI. So you'd have to go in and have, say somebody is, let's say if they know cultures, you'd have to go back and take a look through the medical record, say, well, they got IV antibiotics, their fever went away after 24 hours, they're no longer vomiting, and they were treated for a total of 7-day course. So we're going to presume that that's a UTI. And if that's your exposure or your outcome, then you've defined that, you've adjudicated what it is, and then you've made sure you have a process to adjudicate across all studies. And then that's a good way to have clear definitions, and it minimizes bias. And it's really important to do that. And so those are just things that that help reduce the bias every single time. It is more complex to do, but it's really important that you're able to do that across centers and across countries.
Most of this data is EMR data. I mean, what's collected on the electronic medical records, and like from each center, for example, infection or admissions, mortality, KTORV, the calcium, phosphorus, the labs, hemoglobin, things like that. So, and it's retrospective. So,
yes. The more data that you collect, like lab
yeah.
values,
yeah.
The better it is, because you're collecting something that's been calculated, that's been measured, and is less biased. But each of those labs may be run on a different assay. And so the issue for that is you can't compare necessarily a phosphorus in one lab versus a phosphorus in another lab, or creatinine measurements may be different. And so that takes a lot more work. So I think what happens is that even though people think it comes from electronic medical record, there's still the potential for measurement bias. And so phosphorus is a great example, or TAC levels, for example, also vary. And so what you need to do there is say, you know, what's happening above and below, you know, the median or something like that. So there are different ways of categorizing it, but you have to think again, do you need that variable or not? And what I would say in general is most nephrologists want too many data points, and I would simplify it as much as possible.
Thank you. Thank you very much.
I think Valerie was asking about qualitative data analysis. For qualitative data, there's a number of things that you can do too. What's important though is they also have very standardized definitions. And what's really important is how you define things for your qualitative data and coming up with a data dictionary. And then again, when you extract information, you're extracting it in a standard way every single time.
We have another question in the chat. How accurate is extracting data from disease registries? Do you need to transfer the data for analysis?
I think it then depends on what country the disease registry in and how it was collected. And so that really, I think it just depends. It would have to go into more detail. And then do you need to how accurate the data is really, again, depends on how it's defined and how the data are collected. And so there's still lots of bias. Like even in the US, the USRDS, there's still lots of bias. The sensitivity and specificity of some of the data points are quite variable and quite low, but it's all we have, but it doesn't mean that it's the best data out there.
Thank you so much again, Prof. It's 7 o'clock. I don't see any other questions in the chat. And I know you have your Hogwarts tour waiting for you.
Yeah,
so
thanks so much.
Thank you very much for your time and accommodating
Thank
us.
you very
I
much.
hope you enjoy that.
Thank you very much. Thank you, everybody, and happy to
And
take
thank you
questions
to
if people
everyone
want to
who's
email me.
joined.